faculty in this university, and his appointment is in medicine and in the Cardiovascular Division. Phil received his MD from Vanderbilt University, and then did residency in Northwestern University, Chicago, before coming here for his fellowship. During his fellowship, Phil became interested in the work that was going on in my laboratory on electrocardiographic imaging, and really joined the lab in a very active way and became part of the team. And since then, it's been a pleasure to work together and to watch Phil trying to juggle both research and clinical work, which is not an easy thing to do. So, Phil.
Great. Thank you. Thank you. Before I get started, I need to acknowledge, thank you very much for taking the time to be here today. And quite honestly, several people who have been the most influential in my development are in this room. So it really means a lot to me for you guys to be here. The title of my talk is Electrocardiographic Imaging, or ECGI, of atrial fibrillation, but this doesn't really encompass the mission that I'm going for. And so I'm going to jazz it up a little bit and change the title to Pictures from Afar and Burning from Within, Changing the Paradigm of Atrial Fibrillation Treatment. So jazzing this up and really expanding this to the breadth of the research that I'm interested in here. So in the next 45 minutes, I'd like to set the stage for the research questions with really some clinical background. So take it to the bedside and really understand what is the state of art of atrial fibrillation management. And by understanding that, I think we can better identify the obstacles to managing atrial fibrillation currently, and that puts the framework around the research questions that I have. So let's get started. Let's go to a mini medical school here for the next 5 minutes or so, and let's talk about what we do with atrial fibrillation. So it's the single most commonly encountered arrhythmia. It affects anywhere from 2 to 4% of the United States population. Clearly it's age-related, so up to 10% of patients by the time they hit age 80 will have had atrial fibrillation. The way we define atrial fibrillation is particularly unique, I think. We describe it in sort of the pattern that it comes. Your atrial fibrillation either starts and stops, or it starts and continues. It's paroxysmal or it's persistent. We also have another way to describe it as permanent, which is we can't get the darn thing to stop. So it's a very unique way to describe a disease. I can't think of any other disease that we would describe in this way. And the three tenets of treating atrial fibrillation are really driven by anticoagulation, rate control, and rhythm control. So the anticoagulation is to prevent stroke. AFib by itself is not life-threatening, but it certainly increases the risk of stroke. And so treatment with aspirin or Coumadin, or more recently dabigatran, can decrease that risk of stroke. The idea of rate control has to do with slowing down the heart rate during atrial fibrillation. But what we're going to spend most of our time talking about is rhythm control, talking about trying to maintain sinus rhythm. And that can be done with antiarrhythmic drugs, cardioversions, ablation procedures, or surgery, surgical maze procedure, which we'll talk about. And so my patients oftentimes ask me, they say, well, why do I have atrial fibrillation? What are the mechanisms? What started my atrial fibrillation? And unfortunately, we don't have a great answer. Now, this slide summarizes over a century of dedicated, intense investigation into the mechanisms of atrial fibrillation. And I think it's fair to say that there are factors that promote atrial fibrillation, such as increased tissue mass or size of the atria, short refractory periods, slow conduction through diseased atria, regional conduction barriers, oftentimes from the anatomy that's in the atria, electrical heterogeneity, and vagal activation. All of these things play a role, and have played a role, certainly in animal models. To what degree these play a role in the human models still remains a question. And so when we start thinking about the major obstacles to treating atrial fibrillation, one of the big ones is that we just don't know the particular instigators or perpetuators of atrial fibrillation in each patient. We just don't know that information. Additionally, our treatment isn't very good. We have drugs that are called antiarrhythmic drugs, but I'm going to say that that's a misnomer. They're actually not very effective. We don't really have good therapies to prevent atrial fibrillation from developing. All of our catheter and surgical therapies have some fundamental flaws that we're going to go over. And most importantly, we don't have an accurate way to phenotype atrial fibrillation. It's hard to think about doing experiments if you don't have a very classic phenotype to work with. So I'm going to use an example, and AJ, I'm going to pick on you here. So pretend like a doctor had told you, or one of your family members, that they have cancer. What are the things that you would think about? What questions come to mind?
What are my risk factors? Why did it happen in my family?
Okay, why did it happen in your family? What other thoughts?
What can I do to prevent it?
Okay, very good. I might want to know, what kind of cancer do I have? Where is it coming from? Is it going to respond to the treatment options? Is it something I can have surgery and cure? Is it something that I'm going to die from? If you don't have an accurate way to phenotype this, and if we use our atrial fibrillation phenotype, in this example, we're really left scratching our heads. So what kind of cancer do you have? Well, you have the type of cancer that starts and stops on its own. Where is it coming from? You know, where in the left atrium does atrial fibrillation come from? So where in the body is cancer coming from? Not sure. Most of the time it comes from the lung and the breast. Do I have any surgery options? Well, perhaps we can cut out part of your breast and part of your lungs, and maybe it will work. We generally don't have a good phenotype for atrial fibrillation. And if we did that for cancer, that would be a silly way to go about. But fortunately for cancer, we do have things like imaging. And so if I showed this chest x-ray, AJ, now it puts everything into perspective. This is a patient who has lung cancer. And we know the natural history of lung cancer. We know what the treatment options are for lung cancer. And so having an accurate phenotype is essential to be able to develop the natural history and ultimately develop personalized treatment plans for this particular disease. And so our example of, do you have atrial fibrillation? My hope is that by the time I'm done with medicine, that we'll have answers to this. That when somebody says, you have atrial fibrillation, and the patient says, well, what kind? Oh, you have your atrial fibrillation that starts and stops and comes from the left superior pulmonary vein. It happens to be an atrial fibrillation pattern that is very responsive to medicines. We can also do an ablation procedure targeting that area. It would be very nice to know better phenotypes for atrial fibrillation. So what do we have for imaging? Well, we've got a technology that's over a century old. Fortunately, we don't make people put their hands and feet in buckets of water, but really our technology right now for atrial fibrillation is the electrocardiogram. And so this is what atrial fibrillation looks like. And probably one of the very simple things you can start with is a coarse AFib or fine AFib as a way to start trying to figure out a phenotype. But this is as good as we get. Now, what do we know inside the heart? We've been putting catheters inside the heart and studying atrial fibrillation, and this is what it looks like. And so for those of you who aren't very familiar with these intracardiacs, the top 3 rows here are the surface leads. This 4th row right here is the ablation catheter, which in this case is in the left atrium. I have a catheter here that has 4 electrograms shown here. That's in the coronary sinus, so that's essentially showing you left atrial electrograms. And then on the bottom I have a ventricular catheter, so it's showing you the ventricular electrograms. I think you can get an appreciation that atrial fibrillation is a very high-frequency event, that it doesn't seem to have much order buried within here, that it's a difficult one to fully understand based on these limited electrograms that we have in the heart. And we don't know much about atrial fibrillation, but we have been lucky to capture some pieces of physiology. And one of those pieces of physiology is shown here, and this is the type of physiology that Dr. Hasseger originally described in the early 1990s. And so this is an example of a sinus rhythm beat in the front. That's an atrial beat with a ventricular beat, atrial beat, ventricular beat. And then you'll see there's a run of atrial premature beats, or atrial tachycardia. This is the sort of process that can start atrial fibrillation. And in this example, I have my ablation catheter in the left superior pulmonary vein. And as you can see here, each one of those atrial premature beats is essentially preceded by a signal in the left superior pulmonary vein. And all of them, all of the subsequent 10 beats, look like they're being driven by this process that's starting in the left superior pulmonary vein. So this at least gives us an idea that the pulmonary veins are a major, though not entire, contributor to atrial fibrillation. And by and large, this is what our ablation procedure is targeted to. So this is, these are some images from the 2007 consensus statement, and this is the best of our knowledge of atrial fibrillation mechanisms. And on the left, you see that they mentioned focal triggers, mostly coming from the pulmonary veins, though you'll see stars everywhere else. The posterior wall, the appendages on the right side of the heart. And additionally, there's a contribution of rotors and reentry that's not fully defined in each patient as well. But by and large, our ablation procedures, the state-of-the-art right now for atrial fibrillation treatment, seeks to encircle the pulmonary veins with lines of ablation that trap that atrial tachycardia in the pulmonary veins and don't allow it to come out into the left atrium. All right. And it clearly says in the guidelines that although much has been learned about the mechanisms of AF, they remain incompletely understood. And because of this, we can't precisely tailor an ablation strategy to an AFib mechanism, if only we knew that information. Do pulmonary vein isolations work? The answer is yes, most of the time. For people who have paroxysmal AFib, or start and stop AFib, it's about 70% effective for one particular study. And here's a randomized study of ablation procedure over 1 year, and you can see it has a roughly 70% efficacy, versus drugs. Remember, these are the so-called antiarrhythmic drugs that have about a 20% efficacy at a year. So clearly we're moving in the right direction, but it's not a 100% cure rate. We can do better. Perhaps most importantly, though, is that it doesn't seem to work very well for non-paroxysmal or persistent atrial fibrillation. The longer you're in atrial fibrillation, the remodeling process takes over. It makes it a very different sort of atrial fibrillation. We see lower success rates with this strategy. And in particular, it has a complication rate that's not trivial. I told you atrial fibrillation is not life-threatening, and I'm talking about a 2 to 5% complication rate. That's something that warrants some attention. So what is an ablation like for a patient? In general, they come to the hospital in the morning, and it's about a 4-hour procedure. And we gain access to the heart through femoral veins, and so you can see a couple of sheets coming out of this patient's femoral vein. Mitch, that might be you. I know you don't like to wear hats in the lab. And in general, we run long tubes or catheters up into the heart. We actually puncture across from the right atrium to the left atrium using a needle. And then we can carefully map around inside the left atrium. And this is an example of a CT scan that's shown there. And let me make sure that we can get this movie to show. This is a movie of a very fast version of a pulmonary vein isolation. This is a picture of somebody's face, and this is their left atrium. This is done an electroanatomic map that I make with a catheter. You can see that we're moving around. That's the appendage, and this is going to be the left inferior and left superior pulmonary veins. I can overlie the CT scan that we obtained the day before and try to register those. And so then ultimately what we can do is start doing our ablation. And it's done on a point-by-point sort of basis. And what we'll see here, I'll make our CT scan a little more transparent so you can see through it. And then I'm going to start adding ablation lesions throughout here. Again, every red dot that you see is roughly 30 seconds in one point. So you can see I've added 4 or 5 red dots here across the top. I'm going to add a few more across the back wall here. Now I get concerned as I come across the back wall because there's an esophagus running right behind it. So I label the esophagus. You'll see some yellow dots come through. There we go. That's where the esophagus is overlying the atrium, so I certainly don't want to ablate there. So now let's continue making more dots, more ablation lesions throughout the inferior side of that left pulmonary veins, and then again around the front. If each of these dots takes 30 seconds to a minute, you can imagine how long this procedure can get. And I'm just showing you the left pulmonary veins. We can rotate around to the right pulmonary veins now and repeat the process. Trust me, it looks just the same as the left. We'll move on. So it's a procedure that's involved. It's complex. And part of me wants you to see that and say, gosh, that is really amazing stuff. That they're able to enter the left atrium from the inside of the heart and pinpoint these areas to do ablation point by point. So part of me wants you to really appreciate how complex and how difficult that is. But part of me wants you to appreciate that that did not take it all into account the physiology. That was entirely an anatomic ablation. It was drawing 2 circles inside somebody's heart. And we didn't take the physiology at all into account. And so really, wouldn't it be nice to ablate only the tissue that we needed to ablate and nothing more? That would really be the ideal ablation procedure. If we could move from an anatomic ablation to a more physiologic ablation, we'd be making some headway here. If we could identify patients who might benefit from a certain type of procedure, or maybe even patients who would not benefit from these procedures. These are important sorts of things to think about. And quite honestly, it's all driven by having more accurate phenotypes. If we can describe and understand each individual patient's atrial fibrillation, we can make these decisions. And that works our way into the research that I've been working on with Dr. Rudy and others here. And that really is three research aims. One is the mechanism of atrial fibrillation, we'll spend some time talking about. The other one is the interplay between the substrate and the mechanism in the atria. And the third one is how can we improve treatment. So let's talk about mechanism first. And in general, by its nature, atrial fibrillation is a dynamically changing activation sequence, so we don't have a gold standard map to compare to. The best that we have done has been epicardial plaques, high-density mapping systems, but that's invasive, and atrial fibrillation rarely repeats itself. So we don't have a gold standard to compare to. So we used ECGI, and we have to use it in an important and creative sort of method. And in particular, we need to validate it in the atrium. We need to correlate it to atrial events or atrial arrhythmias. And then ultimately, we need to find a way to quantify or describe atrial fibrillation. So this is our validation phase. And what we did was we did ECGI at the same time as atrial fibrillation ablations in 6 patients. And we did pacing from various cardiac structures and compared the non-invasive ECGI to the invasive pacing maps. And this is an example of pacing from the right superior pulmonary vein. This is an isochrone map where the earliest activation is in red. You can see this large area of red that's earliest activated. Additionally, you can look at potential maps. In the area of local negative or local minima is the area where the pacing is occurring. So here it is in the right superior pulmonary vein. When you overlay the non-invasive and the invasive maps, that's shown here. So the invasive or cardo pacing points are here in green, and the predicted non-invasive ECGI is in yellow. You can see a close correlation between those 2 points. When we looked at the accuracy of identifying the correct part of the heart, the correct cardiac structure, it was 100% accurate, and it had roughly a 6 millimeter accuracy compared to those invasive maps. So from a validation standpoint, I think it stands tall. We've been able to correlate these non-invasive maps with atrial arrhythmias as well, and this was one of our first examples. This was a patient who had been through 2 prior ablations for atrial fibrillation, and she came back with an atrial tachycardia. We were able to do the ECGI, and the reconstruction isochrone suggests that the earliest region during this atrial tachycardia is on the roof of the left atrium, shown here in red. And when catheters go in and we do the invasive map, this is the left atrium, the right atrium is excluded, but just on the roof of the left atrium is the area of earliest activation in the area of successful ablation. And so we were able to non-invasively determine where that atrial tachycardia was coming from. So just additional correlation. During those 6 correlation studies that we did, we saw a number of atrial tachycardias or atrial flutters. One of them is shown here. It's a septal atrial flutter or a septal atrial tachycardia. It's difficult to discern these in the EP lab at once, but with a single beat here, we can see this sort of re-entry pattern where it goes from red to orange to yellow to green to blue. And if I remove the right atrium and just look at the septum of the left atrium, you can see the entire circuit of roughly 180 milliseconds, which was the cycle length of this person's tachycardia. The entire circuit is explained here on the septum between the 2 atria. And so we've been able to non-invasively image the entire circuit of this arrhythmia with a single beat. So additional correlation. And interestingly, mapping did say that atrial septum was involved in ablation across the atrial septum up to the right inferior pulmonary vein, terminated the tachycardia of this patient. So correlation is there. So finally, we need to quantify. We need to look at atrial fibrillation, because everything I've shown you so far is pacing or some other more regular atrial event. I need to show you atrial fibrillation. Our goal here is to explore the abilities and the limitations of ECGI in a wide range of clinical atrial fibrillation. And we've done over 60 patients, but I'm going to show you the first 36 patients here. And in general, a third of them are paroxysmal, half of them were persistent, and the remainder were long-standing persistent. And it's a wide range of phenotypes. Wide range of age from 31 to 76, wide range of duration of atrial fibrillation from 1 month to 30 years. A big difference in terms of the size of their atrium, from 3.5 to nearly 6 centimeters. So a fairly wide range of atrial fibrillation. And what I want to show you are 2 examples of the extremes, because it's always easy to see the extremes. So the first one I'm going to show you is paroxysmal atrial fibrillation. this is an example of 800 milliseconds of paroxysmal atrial fibrillation. And what you're going to see is you're going to see the left atrium. I'll show you here. It's a posterior view of the left atrium and the right atrium attached. So this is the left atrium, the right atrium with the 4 pulmonary veins coming out. And what you'll appreciate is this left to right gradient, that there seems to be the sweeping action of the wavefront as we animate it across the left to the right. There's a delay in the left posterior left atrium as well. Perhaps most importantly, though, is you'll see that this radial pattern comes from the left inferior pulmonary vein. That radial pattern of activation from an area that had not been activated before. This is suggestive of a focal site in that left pulmonary vein. Roughly 200 milliseconds later, we see a similar phenomenon right here, with the radial spread also from a left pulmonary vein. Not exactly from the same spot, but also from a similar spot. And again, we keep seeing these wavefronts that move left to right in this particular patient. I think you can appreciate that there's roughly 1 or 2 wavefronts that seem to be active at one point based on our imaging here. Let's close that down. And let's look at the other side of this. Let's look at long-standing persistent. A patient has had atrial fibrillation for over 5 years now. This is 900 milliseconds of AFib. You'll see the 2 atria, the left and the right atria as well. But I think you'll see very clearly right away that the pertinent findings here, there's far more wavelets that are active at the same time. And the wavelets behave in a very different way. So here's the left atrium, here's the right atrium. And I think you can see right away that there's 2, 3, sometimes 4 wavelets that seem to be active at the same time. That these wavelets are not sweeping left to right, that there's a high degree of curvature. There are areas in the left atrium where there's pivot points around which these wavelets move. You can see these wave breaks. There's going to be a figure of 8 type pattern across this left atrium as the waves sort of split and continue and move around. So this is a very different atrial fibrillation pattern than what we saw before. So this, I think, is the first step towards really trying to figure out a patient-specific physiology. And in those first 36 patients, we were able to get high-quality images in all but 1, and almost all of them had at least 2 simultaneous wavelets. The range that we were able to see was 1 wavelet to 5 wavelets in terms of the number. And individually, each patient tended to have a consistent number of wavelets on each of the movies that we made. About 70% of patients had these focal sites. And this is what the isochrone maps of these focal sites look like. These are left inferior pulmonary vein, left superior pulmonary vein focal sites. But more importantly, 62% had focal sites that seemed to originate from non-pulmonary vein locations. And those were locations that were seen in animal models as well, such as the posterior wall, the coronary sinus, the lateral right atrium. So we're able to image that as well. There's some debate, great debate in the literature about the mechanisms of rotors. And we saw about 15% of our patients had some type of circular activation pattern that we called a rotor, but it rarely sustained more than 1 full rotation. So it was a partial rotation, and then the wavelet moved down. And they were only seen in patients with persistent or long-standing persistent AFib. So when you divided patients by paroxysmal, persistent, or long-standing persistent, the paroxysmals had fewer number of wavelets and fewer focal sites. And it ended up being statistically different from paroxysmal to persistent to long-standing persistent. And we calculated a complexity index, which was nothing more than just adding the number of wavelets and number of focal sites for each patient. And patients who were paroxysmal had a relatively simple form of atrial fibrillation, while the patients with persistent had a relatively complex form of atrial fibrillation. There's quite a bit of overlap between the persistent and the long-standing persistent. So where do we go with all this? Well, let's look at the substrate. So how is the substrate of the atrium contributing to the mechanisms of AFib? And it's thought, as we mentioned, that pulmonary veins harbor most, but not all, of the electrical activity. But it's clear that an atrial cardiomyopathy develops over time, and that it happens at the cellular level. And these histologic changes are shown in our catheter mapping by low voltage. And so this is an example taken from the University of Utah's work using MRI to really try to understand what these histopathologic changes are. And I'll start you out by looking at the electroanatomic map. Those are the maps that we'd seen before. Anything that's pink is considered healthy. Anything that's not pink is considered lower voltage or diseased. And so these are the patterns of disease that they see in this patient. At University of Utah, they're able to use proprietary MRI to delineate similar patterns of scar. Interestingly, we haven't been able to replicate this, but this has been shown in the literature over and over now. So we decided, can we look from an electrical standpoint and find the electrical scar, because this is an electrical phenomenon. And so we looked at those 6 patients who were undergoing pulmonary vein isolation, and we were looking not at the activation patterns, but at the size of the electrograms across the atria. And this is an example of just the left atria of one of these patients, and there's the 4 pulmonary veins labeled. And I divided it into 9 regions, and you can see that ultimately this is the voltage that's associated in the areas. And by and large, this is a green atrium. And here green associates with roughly a 0.3 millivolt atrial signal. And this is sort of time-lapse photography before a pulmonary vein isolation, after the right pulmonary veins has been isolated, and then after the complete lesion set of the left and the right pulmonary veins with a couple connecting lesions. And overall, I think it doesn't take too much to say I've turned a green atrium blue. I've taken an atrium that's essentially 0.4 millivolts before and almost exclusively turned it into less than 0.1 millivolts. Wanton destruction of the left atrium with this pulmonary vein isolation procedure. And we're able to track that throughout the course of an AFib ablation. All 9 of the regions had reduction in terms of their voltage. Interestingly, the lowest voltage happens in the lowest voltage drops seem to happen in the inferior and middle ranges, not so much the superior edges, which is where the atrial tissue is thickest.
So
Yes, sir.
Technical question. What is the voltage reflecting? That is the variance of the voltage?
So the voltage is the amplitude of the signal that we see, and it's representative of the level of disease in the atria. So when we put our catheters in the atria, we see areas of scar are associated with lower voltage. And so unipolar here, we're able to see these areas of low voltage as well as we do our ablation.
Relative to what as ground?
Well, there is currently with endocardial bipolar mapping, there's been normals that have been looked at in terms of what the normal range are. And there has been sort of a standardized version of what low voltage or scar has been associated with.
Well, so there are what it's actually sensing. I mean, is it a continuously, I would guess, depolarized piece of tissue, which would have been closer to 0?
It's looking at the P wave morphology on the amplitude. So this is done in sinus rhythm, and it's the amplitude of the local electrogram that's been computed.
So it's reflecting local dispersion of voltage.
That would be a way to look at it, yes. That's a reasonable way to look at it. So I think what's most important with this is that we're able to see the reduction in terms of the voltage, or the ablation that we're able to do. And this is an example, again, before, during the right pulmonary vein isolation, and then during the complete pulmonary vein isolation. And again, we're turning a green atrium blue. What's probably most important here is, at the end of a procedure, we put our catheter inside the pulmonary veins and we test. We pace to make sure we cannot get across this line. And this is a patient who had a good endpoint, who had entrance and exit block, are the words that we use. But 3 months later, this patient recurred. And it's commonly seen that during recurrences, there's reconnection between the pulmonary vein and the atria across those ablation lines. And when this patient was studied again, when we put catheters back in the heart, it was the left superior pulmonary vein that had reconnected. And when you go back and look at the information from the index ablation here, you can see that this is an area of relatively preserved voltage. Although this had entrance and exit block, perhaps we should have been doing more ablation here to achieve a more durable long-term result. It's an N of 1. It's not a conclusion to make, but it's interesting to see the data show this. So let's move away from the mechanism. Let's move away from the substrate. Let's talk about how we can treat atrial fibrillation better. How can we improve on what we have? I think a logical extension of ECGI is to say, can we direct ablation? If I can see what causes atrial fibrillation, can't we just ablate that area and see? And that's work is in progress towards that idea. This is an example during atrial fibrillation of a repeating pattern that we saw, where a wavefront would gain access to the left atrium up from the inferior side. And so we'd see this pattern over and over. And interestingly, ablation around the right inferior pulmonary vein ultimately caused the atrial fibrillation to stop. And so logically, instead of making 2 big circles, it would seem to me that it would be better to just focus an ablation right here. and perhaps we can solve the problem with far less ablation. This is an example that I showed earlier of that patient who had left pulmonary vein triggers that we could clearly see. Wouldn't it make more sense to just encircle the left pulmonary veins and leave the rights alone? And when we start looking at the differences between paroxysmal and persistent, I've shown you very nice pictures of paroxysmal, which shows circles around the pulmonary veins. But in truth, the longer patients are in atrial fibrillation, the less likely it is for that to be an effective ablation set. And so this is an example of a patient that I've done recently who was in atrial fibrillation. We encircled the lefts, we encircled the rights. She's still in atrial fibrillation. We did a roof line connecting them, that's shown here. We did a mitral isthmus line connecting, she's still in atrial fibrillation. We went into the coronary sinus and we burned within the coronary sinus. I even channeled Ralph Damiano and did the inferior line, which we don't typically do. She's still in atrial fibrillation. And you can see as we rotate this around, there's an area on the anterior surface of a high-frequency site that I ablated. There's the SVC, which I ablated. There's a cavo-tricuspid isthmus line that I ablated. She's still in atrial fibrillation. So despite all of this, she's still in atrial fibrillation. We had to cardiovert her out of it. She stayed in sinus rhythm for 12 hours. So despite all that work, we weren't able to cure her. Now, why not? There's something going on here. We have to figure out what it is. And in general, when we fail, we fail for a number of reasons. First and foremost, I think we fail because we don't fully understand the mechanisms, and we don't fully think that we can, I think we're foolish to think with pulmonary vein isolations that we're able to affect all atrial fibrillation. But recurrences, when we do it, oftentimes do happen with the reconnection of the pulmonary veins. And why does that happen? Well, I move my catheter in, and I put ablation lesions in, and empirically, I think that these are transmural ablations, but I don't really have a way to measure that. And I think that they connect to each other because I pace on the other side, and I have block across that. But what's to say that over time, something will happen over time. Over time, those ablations become smaller. That I'm not certain that I have a full transmural lesion. I'm not certain that that I don't have gaps in the line. And certainly we see recovery over and through lines. There are particular areas in the heart, like the carina, which oftentimes is epicardially attached. And so I'm a little foolish to think that I can do this all endocardially if there's an attachment epicardially. So I got to think, who does it better than me? Well, the surgeons do it better than me. And the surgeons have been doing it better. The standard of care for atrial fibrillation is really the Cox-Maze procedure. They have outstanding success rates reported in the literature. There's an added benefit of taking off the left atrial appendage, which is where we think many people's strokes come from. But talking with the people who've developed this, they clearly say that this does overtreat many patients with atrial fibrillation. It's an involved procedure. And there is a higher risk with this procedure, roughly 10% morbidity that's been associated with it in the literature. And so it's a great procedure, but it overtreats atrial fibrillation. So in truth, how can we build a better procedure? How can we replicate Maze success rates? Give me catheter-based risks or less. Give me a durable lesion set that has transmural lesions. I'd love for it to be physiologically based and physiologically tested. I'd like to exclude the left atrial appendage. I'd like to just make this a less risky procedure if possible. So if I could build a better procedure, how would I do it? And I think one of the very first things that you have to recognize is that unipolar ablation, or ablating from one side, inside out or outside in, may not leave a transmural lesion. And so can we bring those catheters together and essentially ablate on both sides? And this is the basis for the development of our hybrid AFib procedure, which is a minimally invasive epicardial and endocardial ablation procedure done on a beating heart with the goals of mimicking a Maze success rate, but give you catheter-type safety levels. And this is the workhorse of that procedure, and it's essentially, what you can see here is a bipolar clamp, meaning that the energy is sent from one jaw to the other jaw. And you can see these jaws are essentially grabbing on to the neck of the left superior and left inferior pulmonary veins. So this tool can be introduced through small ports on the side of the body and give a true linear ablation as opposed to my single spot welds from the inside, and can do it faster, roughly 15 seconds. We do a couple ablations, makes it 45 seconds. So it potentially is faster, it's linear, and it should be bipolar, so it should be more durable. Additionally, during this procedure, we can exclude the left atrial appendage. That's what it looks like when it's out. And this is essentially what this procedure is about. The surgeons come down to the EP lab, and the surgeon starts by doing a pulmonary vein isolation with that clamp on the right side, then moves to the left side, does a pulmonary vein isolation on the left, and completes this box lesion set that isolates the left posterior wall. I go in with catheters, and I can test how well these ablations have taken hold, test that the posterior wall is indeed isolated, and add additional ablation from the inside as necessary, including additional lines like mitral isthmus lines or right-sided lines. So it adds a bit of flexibility to the procedure as well. And so the theoretical advantages. It's transmural because I'm ablating from both sides. We've got straight lines that should minimize gaps. I should avoid some esophageal trauma because most of the ablation is being done from the outside in. And we've got testing of surgical lesions. I realize that there are real disadvantages as well. This hurts more than catheter ablation. It's a longer hospital stay, though not by much, and there are risks of serious events as we understand this procedure better and better. This is an example of what it looks like in the operating room. So here we are doing surgery on this patient with essentially a closed chest. Got a port on the side, and we've got some ports on the inside here. This is what it looks like. Let's see if I can get the movie to play. I might be rolling the dice a little bit here. This is Dr. Mark Lemaire from Maastricht. The handsome gentleman behind him is Ralph Damiano. And you can see that the surgeons are nodding their head and saying, boy, this is a difficult case. It's tough to do AFib ablation. And I like this procedure because you'll see that the electrophysiologist is back here flirting with the nurse. So this is AFib ablation going on, and that's the EP standing there waiting his turn. And we do see some real results. This is from our second patient who had the hybrid procedure. This is I've gone in and done the map of the left atrium. This is the left superior, left inferior, and the right pulmonary veins. Again, red is area of low voltage. Pink is area that's relatively preserved. And you can see all of these yellow dots. These yellow dots are areas where I have tried to pace and I'm not able to capture. So these are areas that have been ablated. And I think you can appreciate that the pulmonary veins have been ablated, have been isolated. There's this inferior line underneath here, which is red, and I can no longer pace on that area. I'm going to rotate that around. That's the inferior wall. But as I rotate over the top, I think you can appreciate that that red line doesn't fully connect, that there may be a little bit of a gap right here. And this is the value of having an electrophysiologist to go in there and test these ablation lesions. So what I do is I put that catheter right smack in the middle, right here, and I pace. And if I'm able to capture the atrium, it tells me that this is not complete. And so I move around. I try here. I'm able to capture. I try here. I'm able to capture. And so I move around and see where in this box lesion set does it seem like I have breakthrough. And I think it doesn't take very long to see that that's going to be up in this top area, that our roof line is not yet complete. And so ultimately what that means is we should complete that roof line. So you see a number of red ablation lesions, which is my contribution to this ablation, across the top to complete that line. And so you can see we've taken it from left to right superior pulmonary veins. And ultimately, most importantly, what we do then is we go back and we test in the middle of that box. And that blue ball now becomes yellow. Yay. That means that we've got posterior left atrial block at that point, and our ablation is complete. So let's just take a step back. Why are we doing all of this? And where do we go with this? And I can see a way that we could treat atrial fibrillation in a very different way than we currently do. And I think the future of AFib is really personalized AFib management. And I can see a time when patients who are at risk for AFib come in for their screening, and we take appropriate steps to prevent atrial fibrillation. It's a concept that's not very thought of at this point, but if we can take people and get them to exercise and lose weight, and potentially start them on some medicines that are anti-fibrotic, like statins or ACE inhibitors. We can treat their sleep apnea. If we can do all of these things, perhaps we can prevent or delay atrial fibrillation from coming in. If a patient develops AFib, it would be really great to non-invasively really capture what's going on from an electrical, structural, and genetic sort of way. And that could be done with MRI or echo or certainly with ECGI. I think that's an important contributor. And then ultimately we make a personalized treatment plan based on what we see, based on what the atrial substrate looks like, based on what the pattern of atrial fibrillation looks like. You, sir, have an atrial fibrillation that seems to be driven from your left inferior pulmonary vein. I think we should just do a pulmonary vein isolation on you. You, my dear, have a very diffuse pattern for your atrial fibrillation. We should be thinking about a more extensive ablation procedure for you. Perhaps we can target our medical therapy better. If we have one particular behavior of atrial fibrillation, it may respond to a certain class of medicines better. And ultimately, if somebody does have recurrent atrial arrhythmias after a treatment, we should understand why. Is there a way for us to focus our efforts on that recurrence and understand why that happened? So my final take-home points out of all of this is that AFib really is a spectrum of diseases, and we don't have an accurate phenotype. But that ECGI may have a role in non-invasively providing that phenotype, based both on the mechanisms of AFib as well as that atrial substrate, and then combining the knowledge of the substrate, the mechanisms, as well as the tools that we have from intracardiac mapping. I think we can provide a more successful and safer procedure for AFib. So before I take questions, I just want to thank the Rudy Lab family for allowing me to be a part of them over the course of the last several years. And in particular, we should highlight the efforts for the AFib, which have been pioneered by Yong Wang and Ramya Vijayakumar. So with that, I want to say thank you, and let's take some questions. Expected some tough ones from one of these two. Okay, yes. Dr. Damiano.
Great talk.
Thank you.
Very provocative and very well organized. And I just was listening to a lecture from Moritz Alessi, who says reentry never occurs in AFib, and also emphasizing the discontinuities and the fact that it's a three-dimensional arrhythmia. He's right. You know, where do you think that, first of all, I'd mention your impression on his comments, and, and if three-dimensionality is so important, as he seems to be stressing in some of his high-density mapping, though he just maps a very small area. You know, how does that, how do you think that would mean the interpretation of ECGI?
Yeah. Well, that's a great question. I think it should be framed with the admission that Dr. Alessi has made enormous contributions to understanding the mechanism of atrial fibrillation. He will also tell you that all of the three-dimensional research that he's been doing now essentially makes a lot of his old data wrong. So he's 0 for 1 and maybe 1 for 2 on this. But there probably is some three-dimensionality to this. It makes sense that atrial wall is a three-dimensional structure. It's hard to wrap your mind around that much of a three-dimensional influence when the atria is as thin as 2 or 3 millimeters at a time. So I don't know how to wrap my mind around that phenomenon that he's seeing. Particularly, he sees this in long-standing persistent, or the longer the atrial fibrillation, the more it seems as if there's reentry or patterns within the intramyocardium. And I think that has to do mostly with the disease histopathology that happens. I think that has to do with the scar tissue that forms, the fibrosis, the atrial fibrosis that forms. It would make sense to me that you could have three-dimensional reentry or three-dimensionality to your atrial fibrillation, particularly if you had fibrosis in the mid-myocardial layers. How does that relate to atrial fibrillation that we image here? I don't know yet, because all we see is the epicardium. It would be really wonderful to do a combined epicardial and endocardial map and really do our own high density. But we have to recognize the limitations of a high density endocardial map. Our tools are really limited to really get a snapshot of atrial fibrillation for 800 milliseconds that correlates to the same movie images that we're showing here. So I think it's thought-provoking. I don't know how to put it fully in context, but I think it has to do with the fibrosis.
He thinks there's no reentry in atrial fibrillation from his perspective.
He's moved off of his reentry.
Well,
right.
I don't, no, I guess I don't agree with it. I think you start with atrial flutter, which is sort of type 1 atrial fibrillation, okay? And then atrial fibrillation is in degrees of different things that are going on after that. Atrial flutter is understandable. And it's definitely reentry. And the three-dimensionality there is important because in most atrial flutter, what you do is you create a cylinder out of the right atrium, because already you've got the tricuspid orifice anteriorly, and now you've got the vena cavas posteriorly. And now all you need to do is get functional block in between the two cava, and now what you've done is to create the atrium in between those into a cylinder.
Right.
And the larger that cylinder, the more evidence there is of slow conduction somewhere in it, the isthmus or wherever that is, the more likely you are to get atrial flutter. And you can probably produce atrial flutter in almost anybody. It won't be sustained, but you can. But given that situation, it's certainly three-dimensional, and it's reentry. I mapped atrial fibrillation back in the 70s. I wasn't meaning to. I was mapping atrial flutter in dogs, and 2 or 3 animals I was able to map it, and it had a single circuit. Now, that circuit looks focal if you don't have a high density of electrodes, but it's reentrant. It's micro reentrant, or can be. And the wavefront, as it disappears or as it moves away from this very fast reentry, which is basically left atrial flutter, it dissociates.
Right.
Because the time it takes the wavefront to get from this reentrant circuit in the left atrium all the way out to the right atrium is longer than the reentry in the left atrium. So you have multiple wavelets in the right atrium, and it looks exactly like atrial fibrillation.
Right.
But it's not.
So we should put you and Dr. Alessi in the same room and get this sorted out.
Sure.
I think Rick and I were talking beforehand, and we've got so much knowledge about atrial fibrillation and people who've had their hands on with high-density maps. I mean, there's more people in this room than in most states who've mapped atrial fibrillation before. And I think when you start looking at all of the different proposed mechanisms, particularly in the animal models, I think they're all right to some degree. That you can't tell me that all atrial fibrillation fits in one mechanism. Not when I showed you that data. Not when I showed you what that persistent looks like and what the paroxysmal looks like, and they're very different. So I think for some patients it would make sense that there is reentry and fibrillatory conduction. It's probably how many patients have AFib. But I have to think that other patients, like what have what Dr. Alessi shows.
Well, a lot of it's dissociation and not reentry. And once you have multiple wavefronts trying to get or in the heart, and they can't get out fast enough because the other wavefront's coming along behind it, and the refractory periods are different, they're going to give you multiple dissociating wavefronts.
Right.
That's not necessarily reentry.
Right.
Okay, I think that